So my theme is to leave nobody behind. My theme is to try to maximize the opportunity for my patients to be one of these long-term responders with either bevacizumab or PARP, or maybe both. But in today's world, you said it's unethical almost to not test and to not give olaparib in the frontline BRCA-positive group. Do you feel the same in platinum-sensitive PARP-naive patients? We now have 3 FDA approvals: Nova niraparib, Ariel 3 rucaparib, and Solo 2 and Solo 19 olaparib. Is it as equally unethical to observe that patient after a response to second-line platinum?
Right, so that's a more complicated question. So yes, I think it's equally unethical not to give women with BRCA germline, somatic, HRD positive mutations. And I actually think all of those, because we know so little about homologous recombination deficiency that there's going to be subsets of women within that group that are going to respond beautifully, and we all have seen them. I think the bigger debate is women who are truly BRCA wild type and homologous recombination proficient. That could be the debate of the 3 months. Do you believe that to be I believe it to be the benefit for all my women, because I feel like we know so little, and there's going to be women there who will benefit, even if we don't know that.
Leave no one behind.
Leave no one
and
behind.
To your point, yes, this HRD signature might be able to predict, but we can't do that. Even in the BRCA negative, HRD negative patients who respond to second-line platinum, which in and of itself is a biomarker.
Exactly.
Patients can do well for a long time. So is it ever acceptable to take a patient in second-line platinum responders and observe them?
Is it acceptable? It is acceptable.
Why?
If the patient chooses that.
Okay, fine.
So I don't think that it is. I don't think
That's
that
an
it
easy
is.
answer. That's an easy answer.
Well, but I don't think it is. In the NCCN guidelines, actually listed as an alternative. I don't think it's an equivalent alternative personally. I think that what we've learned, again, there's all these like the primary analyses and then what you really learn from the studies. So you just listed Nova, Ariel 3, Solo 2. Solo 2, most importantly, in a BRCA population, all the patients who apparently we cure and do amazing with nothing, if you give them nothing or placebo, their median progression-free survival is 5.5 months.
All of them are 5.5
exactly
months.
the same as the other two. They do no better.
They do no better.
And so you set patients up to be subsequently resistant to platinum by just leaving them on nothing. And so I think we've learned that now, and maintenance has a much more important role than where you could get therapy or you could not get therapy. If you tell a patient that, they're going to say, well, I don't want any therapy. But you have to tell them what the ramifications are. But some patients need a break, and it's shared decision making, and they want a break. So do I think that's acceptable? Sure, it's their choice. I would never present that as the equivalent option.
So we have 2 elephants in the room with that second-line platinum-sensitive relapse. One is Bev versus PARP, and the second is which PARP. So Brian, I'm going to have you take the Bev versus PARP. If you have a Bev and PARP naive patient in good performance status, no contraindications, and she says, Dr. Slomovitz, you're world famous, you're in charge of the service at Miami. Which one do you want me to go on? Do you want me to get bevacizumab, a la Oceans 213 or this carbo-PLD bev, or do you want me to respond and then I'm going to get one of the 3 PARPs? How do you answer that?
No, I appreciate the question.
In the room.
It's the elephant in the room. So, when I look at all my patients with ovarian cancer, I don't look at them specifically in a vacuum at that line of therapy. I feel strongly that all women with advanced ovarian cancer in their treatment course, all women deserve at some point, they deserve Bev, and at some point they deserve a PARP inhibitor.
Leave no one behind.
So I'm follow me on this. So I believe that all women, regardless of their status, HRD, they all deserve Bev and they all deserve PARP. Right now, the way that the guidelines are written, the only time that we could give them a PARP inhibitor, all women, is after platinum-sensitive response. So based on that, again, you want me to tell you what's happening in that room. I'm looking across the course of their disease. With my frame of thinking, I'm giving them Bev in the front line, except if they're BRCA, because the Solo 1 data is game-changing. It's seeing treatments where we've never treated this disease before. I'm giving them Bev in the front line, and I'm giving PARP in their second-line therapy. Now, if to answer the question more specifically, in a patient for some reason didn't get Bev in the front line, I'm really not sure of the right answer what to give them in the second-line maintenance, Bev or PARP. I'd probably lean towards PARP because that's my opportunity right now to give them a PARP.
What do you think of that?
I do exactly the same. You know, I save my bevacizumab for the Aurelia study for the women who become platinum resistant, and you know that's actually going to make a difference. And I do exactly the same with
Or
with
frontline
maintenance.
in the high-risk patients. you
Oh,
also
frontline,
said.
of course, of course.
So-
And you know, and I think Katie, I mean, you said it so beautifully about a shared model of decision making. But I think a big part of the patients in these recurrent settings are not appreciating is that the cancer is never gone. You know, I think all these recent studies on circulating DNA and tumor, and I think that very much changes my conversation with the patient. Like when I say to her, you know what, you know, we see nothing on CAT scan, but I know from studies that unfortunately there's still cells, and those cells will come back. And I think the change is kind of the conversation.
So I worked on all these labels, and people would always say, Monk, is it maintenance or treatment? And if you look at the label, it says maintenance treatment.
Right, right.
Right?
Yes.